What is diabetes and how does it behave?
My grandparents both had diabetes on one side. My father's siblings, 3 of them had them.
The pump can know what your continuous glucose monitor thinks your blood sugar is and can make its own decisions about how much insulin to give you.
Welcome back, and thank you for joining me. Thank you for all the support you've given us. We wanted to talk a little bit about a subject which is very close to my own heart, diabetes. It's very clear to me that the burden of diabetes in India is significant and worldwide is significant. But what is diabetes and how does it behave? And why are we talking about this now? Diabetes in a way is a silent killer in its different types of presentations, mainly because type 2 diabetes, which is adult onset and often doesn't show up until someone is 45. In India, we're a diabetes capital for the world. I've got a great interview with my colleague, Dr. Norris, who happens to be my roommate from med school and is now a professor at the University of Iowa on juvenile diabetes, something he knows well because he's researching on that. And we'll share that with you in this particular episode. Welcome back. I'm very proud and very honored to have Dr. Andy Norris with me today. He is a MD PhD who actually trained with me and was my roommate at Washington University. Prior to that, he had been at MIT and he did his PhD at WashU along with his MD, and then went to Boston Children's and Harvard to do his pediatric endocrinology graduate work, and then went on to the University of Iowa to teach. He's authored over 56 peer-reviewed papers, had spoken at over 90 different conferences, and he is well reputed and a professor of biochemistry as well as clinical pediatric endocrine. It's an honor to have him on board. Let's turn a little bit now to diabetes. Let's go ahead and define it as a role. I know obviously you and I have done our readings, but for the audience, type 1, type 2, type 1 is generally an immunologic phenomenon, and it's not hereditary in the twin studies or anything else. Yeah, tell us a little bit about type 1, and then let's switch over to type 2 for a little while, and then we'll come back. So type 1, I suspect you see a lot of in the pediatric realm. Is that true?
Yeah, this is probably 85 to 90% of the children we see who have diabetes have type 1. The remainder have type 2 or some very rare forms as well. Type 1 is caused when the body destroys the cells of the body that make insulin. These are called the beta cells. They are in the pancreas, which is an organ in the abdomen. And so type 1 diabetes is actually a pretty simple problem. It's that your body can't make one single hormone called insulin. And if we could perfectly replace insulin, we could perfectly treat type 1 diabetes. Unfortunately, we do have insulin and we can give it, but we can't give it in a perfect way. So it is a difficult disease to manage. It requires attention 24/7 to what your blood sugar level is, how much you're eating, how much insulin you're giving. And so it is a demanding disease to take care of for families, for kids, and for the adults that have it as well. Here in the United States, about 1 in 300 to 1 in 400 or so people will develop this during their lifetime, and usually during childhood, but sometimes during adulthood.
Wow, and so you said some really good things there. One is with type 1, you wipe out the whole function of the organ, the pancreas, with regard to production of insulin.
Yes.
And as a result of that, you're on razor's edge. Now, tell us a little bit about insulin and how it works.
Yeah, so insulin, actually, I gave a lecture today about insulin.
Perfect.
We are coming up on the 100th anniversary of the discovery of insulin.
Wow.
Insulin was first injected into a human in Toronto, Canada in January of 1922. So we're getting close. It was discovered in the summer of 1921. So we're getting close to the 100-year anniversary. Insulin is a small hormone. It is a peptide hormone, which means it's a protein. Normally a cell will make that, and it makes a little bit all the time, And when you eat, it makes a lot. And it gets into your bloodstream and it helps control your blood sugar levels. And so it's a very potent hormone. And it can now be produced by factories, and they put it in a little vial. But because it is a kind of a protein, you can't take it by mouth. And so it has to be injected. And so this is one of the medications has to be given as an injection into the skin. And so when you have type 1 diabetes and also other forms of diabetes where your body doesn't make much insulin, you need to take insulin injections to help control your blood sugar.
And so one interesting point is in terms of insulin's effect, it works to basically allow sugar to be absorbed into cells, as I understand it. But in addition to that, it works both peripherally and centrally. And there's certain organs which rely purely on sugar. For instance, the brain is predominantly dependent on that. So to think, you really need that. So when you get really down on your glucose, when you feel like you can't think, it may be a function of not having enough sugar on board. In the future, I'm just wondering whether you can make an endogenous, exogenous pancreas, which is regulated by hardware.
Yeah, so there are efforts to make a pancreas on a chip or an islet on a chip. Those efforts exist. And I should say that we can get this to work in mice. And so you can take cells that like skin cells from a human, turn them into beta cell-like cells, inject them into a mouse and cure the mouse's diabetes. Getting this to work in a human in a safe manner is a lot harder.
I think one interesting thing you and I should do is focus a talk on this. I think we could intrigue a lot of people.
Yeah.
Raise and maybe look at you heading that. And I can give you the technology platforms and everything else to get that done, because this is the kind of fundamental feedback loop research which I'm looking at doing, which will change the way we look at stuff. The second part is obviously re-engineering and introducing changes which would give you your islet cells back, or sorry, your beta islet cells back, right?
Yep.
All right. So moving forward then, that's the type 1 patients. Tell us a little bit about, well, before we go there, what are the symptoms of diabetes? And I think they're similar in both subsets, perhaps a little more severe in that. So if I'm a patient coming to you, and this is a very important point for both our global audiences as well as specifically our patients, what are the symptoms which we see? And I think we've both seen them, right? Polydipsia, polyuria, all that stuff. But can you define that so that people know what we're talking about?
Yeah. So one of the most basic symptoms of diabetes is excessive thirst and excessive urination. And so drinking a lot, especially if you're having to drink at night and waking up really thirsty and having to urinate at night, this is a kind of a tip-off that you should have your blood sugar checked to see if you have developed diabetes.
Okay.
And so this is kind of the most common, the most basic symptom.
So you're not just talking about a 60-year-old man with big prostate who is waking up 3 or 4 times. You're talking about someone who throughout the day is thirsty and has to pee a lot.
Yeah.
What I've also seen is that they drop weight,
Yep.
that they have other constitutional symptoms, that they just don't feel good. And in some cases, if it's really bad, you know, here in India, oftentimes we have the natural history of the disease. And so I recently had one of our guards in the compound lose about 15 pounds, and they had referred him to me and said, look, what's the story on this guy? We quickly got a standard glucose check with a glucometer, and his sugar was 600.
Yeah.
By all accounts, you should be in diabetic ketoacidosis. We checked his hemoglobin A1C, it was 16. And so we quickly put him onto insulin and some drugs, reduced it. And within about 4 months, the guy, he had to go to his village to recover, and he did recover and came back to work. But
Good.
I would say to you, in India, as well as in the US, this happens in many at-risk populations that really doesn't show any type of preference. I mean, if you have a strong family history, particularly in type 2, which we'll talk about next, it's something which, you know, will show up if you do the wrong things. And even if you do the right things, it may still show up. So tell us a little bit also about the complications of diabetes before we turn to the types.
Yeah.
The type 2s.
Diabetes really is kind of defined by its complications. And when we say somebody meets the criteria for having diabetes, that means their blood sugar is so high that it's going to cause damage to their body in the long run. Now, if it's super high, like the person you just talked about who had a blood sugar of 600, that can cause damage in the short run. But even a blood sugar at 200 milligrams per deciliter over time will cause damage. And the damage that's caused is to the backs of the eye, the retina, the part of the eyes that see, and it's a leading cause, at least in the United States. It is the leading cause of acquired blindness among working age adults.
And that is something which we call flare hemorrhages. I'll tell you an interesting story. We did a very interesting experiment with one of our collaborators, and he created something out of MIT, actually. He's a professor in the camera culture lab. And what they did was they put optics on a camera phone, on a just regular mobile phone.
Oh, wow.
They were able to take fundoscopic exams. They then created this into a very low cost screening tool. And then they took that out, it's less than $80 across India. And it acted as a triage because there were many people who were going blind from diabetic flare hemorrhages, where you get bleeding and the arteries in the back of the eyes get very thin. And as a cardiovascular specialist, we would see this as complications all the time, with the arteries just getting coated in glucose and either calcifying rapidly and early, or alternatively thinning out. And then the second thing we saw was with nerves, where you get neuropathy. And for my vascular practice, many of these diabetics had wounds which wouldn't heal because they had the double whammy in that their arteries would get affected and provide poor blood flow. And then they would also have poor tissue healing because their macrophages and all their other white blood cells in the healing response wouldn't work. And then the last part of the cascade was their nerves would be deadened in a stocking glove distribution, and they would end up with wounds at the bottom of their feet, leading to amputations and things like that. And so we saw it in our practice all the time. Do they live a normal life if they treat their sugars and take it seriously?
Yeah, with good management of your blood sugars, life expectancy has gotten pretty good. Okay. And so you expect 6-7 decades if you've done a nice job of managing your blood sugars with type 1 diabetes.
Okay. And so let's talk type 2. When is the median onset? I'm sorry, you were saying something. I interrupted you.
Oh, I was just going to say, there is a little bit of it, with the right genetics and the right, with just a little bit of luck, you can make it a lot of decades with type 1 diabetes and careful care.
That's very encouraging. With people like you tending to it and all of the other things, I'm certain that we can affect a good future. With type 2, what's the median time to onset and age? And what do you think on the life expectancy? Can it be normal?
So type 2 diabetes is a disease that becomes more prevalent with age, and that's across multiple decades. So your risk of developing it increases as you get older and older and older. It's not really described in children younger than age 4. On rare occasion, we'll see a child as young as age 4 develop it. We've had one such child that I've been part of their care team. But in general, it doesn't happen in children until they go through puberty. And so a typical age of onset would be 11, 12, 13, all the way up to 18. And then of course it keeps on going, but I'm not involved after that.
Sure. And the life expectancy with regard to type 2?
We don't know for kids, because kids have not really been developing type 2 diabetes. When you and I went to medical school, we were taught that kids didn't get type 2 diabetes.
For the most
and then the world kind of changed. And we live in, a more sedentary, more obesogenic environment than we used to.
We'll talk about that in a second, because obesity and morbid obesity has become epidemic. And, I was giving a talk on heart disease in the pandemic, and I said that, look, the likelihood of you dying from a heart attack is 17 times higher. In other words, in the world, there were 17 million people dying from cardiovascular disease, 80% of that being heart disease and strokes versus maybe 1 million total dying from COVID. And so to not come in for chest pain, chest pressure, shortness of breath, or all the typical, or even atypical symptoms if you're a diabetic, it doesn't make any sense. You just need to take precautions and be smart, right?
I would say, you know, the other thing to add to that is that, at least here in the States, hospitals are very safe places to be, because you're going to be people wearing masks, and, you know, all the staff are very careful. We are all screened, and we all know what to look for. And so, you know, it's one of the safest places to be around town is in the hospital. So
that's an interesting question, which we should answer. During this epidemic and pandemic, was it difficult to get care? Because, you know, we looked at the data, and for non-elective surgeries and non-elective care, the volume had gone down drastically to 30% of the total. And there was also a paper published which demonstrated that in elective surgeries, and which are non-cardiac, that the risk of dying if you had COVID was 14-fold higher than baseline. And the other interesting part about that paper was that 40% of the patients who were diagnosed with COVID were diagnosed during or after the surgery. So in other words, they were in transition, because, as you know, they don't develop symptoms in the first 5 days or so.
Right.
Be all the way out to 14 days. And it's a very insidious disease in that 40% of the people may not even have symptoms. But were you seeing that in your practice? I mean, were people scared to come in, and were you seeing complications as a result of that?
Yeah, I fear that we will have complications from that. Interestingly, though, at least for patients for children with type 1 diabetes, what some people have seen, and we've seen it to some degree, is that blood sugar control has gotten better. And here's the reason. It's because kids were at home, not out and about. And so they were under better, and the parents were home because they were telecommuting rather than going into work. And so we've seen some blood sugars get better. We've seen a few get worse. So it's been interesting that way. But I fear that, what I really fear is our patient volumes have gone down some, not dramatically, but some. They should have been going up. And so I fear that there are kids out there with either undiagnosed conditions or who have lost control of their endocrine conditions. And so we're going to see that once the pandemic ends, and we'll be having to, you know, deal with that.
Tell me about that. I know there's devices now which actually have the sensing capabilities and dispense insulin pumps, which are frequently used for type 1 diabetes. Where are we at with the technology? I mean, how far?
We are, so one of the things we hoped for years is now available. And so this is called a semi-closed loop pump. And so this is a little small device, maybe this big, holds some insulin in a vial, attached to a tube that goes under your skin, little plastic tube. So this has existed for a long time, an insulin pump. It existed back when we were in medical school. And those have become pretty good, pretty reliable. But now we also have continuous glucose monitors. These are devices that are pretty small. They have a little plastic tube that then gets inserted, you know, not on your wrist, but sometimes on the back of your arm or on your stomach, just a small distance into your skin. And it stays there for 14 days or so. And it knows what your blood sugar is. It senses the amount of glucose that's kind of in your body, or, you know, sugar and glucose are the same thing.
Do you use those for insulin dependent patients, or do you use them for non-insulin dependent? And
you can use it, anybody can use it. So it doesn't depend upon what kind of diabetes you have. But now what has happened in the past couple of years is that an insulin pump is allowed to receive the information. The technology has existed for a while, but now it finally is, the companies were able to prove that it's safe enough that the FDA approved it to be able to be used in humans. So the pump can know what your continuous glucose monitor thinks your blood sugar is, and can make its own decisions about how much insulin to give you. And these devices work pretty good when they're working. They work really well.
So we should talk about that, because that may be our artificial pancreas going forward. And
Yeah.
the issue is batteries and technology can fail, so you have to have a backup. One of the 101s of heart surgery that
Yeah.
always 2 to 3 redundant systems so that
It's the same thing. We tell all of our patients on a pump, you need to carry syringes because the pump is going to fail. It's most likely going to fail at the worst time, like at the start of a 3-day weekend or when you're getting on an airplane or a car trip to go somewhere.
And so in type 1s, do they really now, it sounds like they can have a life where they're not, checking their glucose every so many hours and doing all that with these pumps, because we don't really appreciate it as physicians sometimes what these patients have to go through. But
Yeah.
you can imagine they're checking their sugars and making sure everything's fine. Do you think we're at the point where these guys can do all normal activity and not worry?
Well, we've been sort of there for quite a while in terms of, at least for teenagers who have type 1 diabetes. They can lead a very active lifestyle and be involved in sports. And we've had medal award-winning high school athletes who've run state championships and the like over the years. So that's been true for a long time. What really the question is what is your blood sugar, for how much work you put into controlling your blood sugars, what kind of blood sugar control do you get out of that?
Right.
And that equation is shifting towards better and better control. Now, when you have one of these smart pumps, semi-closed loop pumps that knows what your blood sugar is and automatically adjusts how much insulin you get, you still have to pay a lot of attention. It's still a lot of work. You have to put these devices on yourself. You have to make sure they're working, which is a lot of work because they're a little bit finicky. And so, there's still a burden there.
Evolution of this could be to a super person in that even in a normal person, you could actually amp up their activity as necessary and do what you need to, because adrenocortical steroids and hormones are naturally there, right? And they kind of up your glucose levels and give your body what it needs during a fight or flight reflex. And similarly, if we can coordinate all of the hormonal activities and understand the feedback loops and create new ones which we can manage, it might be some interesting science going forward. So that's great. Now, I know you don't manage adults and you've kind of deferred from that, but in adults, what are your thoughts on life expectancy and normalcy of life? And going forward, what can they expect if they manage their sugars well?
Well, for type 1 diabetes, one of the gatekeepers, so your blood sugar control really matters. Well, for type 2 diabetes as well. So one of the major determinant of complications, these microvascular complications, so the eye damage, the nerve damage, and the damage to the kidneys, the major determinant of that is what is your blood sugar. The closer it is to normal, rather than being high, the less chance that you'll have those complications.
And I think the one thing to add to that is it's not just when you're tested, but it's the area under the curve.
Yeah, that's right.
How many minutes and hours your body is in contact with high blood sugars? Because the problem is they can game the system and eat properly before they get their hemoglobin, or rather their Accu-Check. The one thing that doesn't lie is something which we call a hemoglobin A1C, which measures glycosylation of your hemoglobin over 3 months. And that is a telltale sign that you've been behaving or not misbehaving, or rather behaving or a bit misbehaving over the last 3 months. So that's actually an interesting data set. All right, well, we've covered a lot of topics, Andy, and I really appreciate all of the time you spent with me. I look forward to having more discussions, both on the more scientific side as well as on the primary prevention side.
So if you have a family member with diabetes, then you have to keep your eyes up from an early age and decide that this is something I don't want to get. Because even if you have the genes, you can modify the outcomes by what you do with your life. And one of those things is watching your diet, which we've talked about in another episode, watching your weight, which we've also talked about in another episode. In addition to that, staying active, because staying active mobilizes your peripheral insulin receptors and allows you to take up sugar. And in fact, when you look at the treatments for diabetes after it's diagnosed, they can range from diet and exercise to oral anti-hyperglycemics to insulin. And in an ideal world, if you can at least get to a very, very disciplined diet, you can potentially come off of the medications and lead a normal life. So then, where are you at on this? And what are you thinking? This is what I want to know. I've given you some signs and symptoms. I've given you what the risk factors and complications are of diabetes, and I've also given you what treatments are there for diabetes. My goal is to try to help you to stay away from it. And living in a country like India with the Indian genes, I'm doing my best. So I want to know from you what you're doing to prevent diabetes and to stay on your path if you have a family history of diabetes or you have diabetes right now, because my hope is we can join hands together and get you to a situation where you're only diet controlled with some exercise and whatnot. Anyway, if you like this video, hit the like button. And if you want to see more like this, hit the subscribe and the bell icon so you can be notified when new episodes come. Don't forget to share this with your friends, because this sort of information will hopefully bring everyone together and start a dialogue on good health care. And finally, enjoy yourself and make sure that you live your best life and join me. I appreciate you spending the time with me right now, and it's always a pleasure to talk to you. I look forward to seeing you again.